Welcome everyone, and thank you for joining us for the second session of the Leveraging Midwifery-Led Care to Address Disparities and Equity in Medicaid virtual learning series. I'm Jennifer Moore and serve as the founding director at the Institute for Medicaid Innovation. Before we begin today's session, we would like to thank our funder, the Yellow Chair Foundation, for their commitment to advancing important maternal health topics, especially in the Medicaid population. Through their generous and ongoing support, we are able to offer this free virtual learning series. This learning series brings together Medicaid stakeholders, including state Medicaid agencies, health plans, and provider groups. With over 300 participants joining the learning series opportunity, we have representatives from 42 states, the District of Columbia, and the federal government, coming together with the shared goal of increasing awareness of midwifery-led care by applying key findings from IMI's landmark report to their national, state, market, or local clinical setting. We have designed the first 6 sessions of the series as an hourglass, starting with a broad overview of midwifery-led care in Medicaid, narrowing our focus to the regulatory and operational environment, and then broadening out to review the policy landscape for the midwifery-led model of care in Medicaid. Underlying all sessions is a focus on birth equity, including how racism and related social determinants of health affect access, coverage, and birth outcomes. We have deliberately left the final 2 sessions open. At the midpoint of this series, you will be asked to identify potential topics and speakers. This will allow you, as the participants, to guide and inform the final content. As you go through this series, please begin to think about what you want the final 2 sessions to be focused on. During today's session, the speakers will provide information relevant to 3 main learning objectives that build upon the required activities that you completed before this session. They include identifying the value of the midwifery-led model of care from the perspective of key Medicaid stakeholders, identifying how access and coverage to midwifery-led care and models of care impact birth equity, and identifying the challenges and opportunities to ensuring access to midwifery-led models of care, including workforce development, collaboration with physicians, and payment models. However, before we get started with the panel discussion, my colleague, Chloe Baxt, will review a few housekeeping items.
Hi, everyone. Good afternoon, and welcome to session 2. I'm going to review a few details for today's session, along with a few reminders. First, today's session will be recorded and archived on the IMI and CHCS website. Except for panelists, all lines will automatically be placed on mute, and during the meeting, the chat feature will be disabled for all participants. We have reserved 15 minutes at the end of the panel for you to ask questions of our guest panelists. To participate in the discussion with the speakers, please use the Q&A feature to submit questions and comments. Please submit questions throughout the session. You don't need to wait to the last 15 minutes to submit your questions. Feel free, as they come to you, to put them in the box. The questions will be consolidated and shared by the moderator during the Q&A portion of the panel. At the completion of each session, you will receive an email message with a link to complete a short 5-minute evaluation survey. I will also put a link to the evaluation survey in the chat for you. Our response rate for the last session was around 40%, and our goal for today is to double that, achieving an 80% response rate. So let's all work towards that goal together. And finally, as with the first session, all materials will be made available to you on the IMI and CHCS websites about 2 weeks following today's date. Now let us get started with today's session. I am very excited to introduce our session moderator, Tricia McGinnis, Executive Vice President at the Center for Healthcare Strategies.
Thank you, Chloe, and welcome everybody. We're excited for session 2. Today's discussion, we're going to explore 2 issues in depth with our wonderful set of panelists. The first issue is, what do different Medicaid stakeholders see as the value proposition of midwifery-led models of care? And second, how are these stakeholders approaching coverage, payment, and contracting to provide access and coverage to midwifery services, especially to communities of color within the Medicaid population? This session covers one component of the action framework laid out in the IMI report. It is important to understand the midwifery-led model value proposition within the broader trends that we are seeing across the healthcare industry today. Shifting care and resources away from unnecessary, avoidable medical interventions that produce little value and lead to high costs, towards person-centered models that have evidence for producing better health outcomes and reducing disparities at a lower cost. It is within the context of these broader trends toward value-based care that many state Medicaid agencies, health plans, and providers are turning to midwifery models of care because they provide high-value, evidence-based contributions to high-quality care. But it isn't just about the value to the healthcare system. Equally important is the value of this model to birthing individuals, their families, and to communities. Dismantling decades of structural racism and social, gender, and economic oppression in Medicaid and the maternal health system requires us to center the preferences, particularly for people of color, in how we approach structuring, paying for, and supporting midwifery-led models of care. We will hear today from our panelists on what approaches they are taking to effectively deploy and drive uptake of the midwifery-led model of care. To tee up this conversation, I wanted to share a select number of recommendations from the case studies on freestanding birth centers that were profiled in the IMI report. They recommended, for example, that state Medicaid agencies and health plans first fund low intervention birthing facilities at a rate that incentivizes their use. Reimburse midwives at 100% of the physician rate for the same work. Reimburse non-clinical supports, including doulas, lactation consultants, and community health workers, in addition to the global maternity care payment. Finance and expand coverage during the postpartum period from 6 weeks to 12 months to increase access to contraception, conduct depression screenings, manage newly diagnosed chronic conditions, and improve interconception care. And finally, support behavioral health as part of postpartum care. The freestanding birth centers featured in the report also recommended that providers know what resources, strengths, and potential partners are present in their communities, that they diversify funding used to support midwifery services, that they consult with individuals and organizations who have done this before. And finally, the birth centers called on all of us to build equity explicitly into the planning and development processes and to ask the community what they need. And with that overview of our discussion, I would like to introduce our esteemed panel members. So to explore in greater depth the key issues of how to approach implementation, I am pleased to introduce our panel. Dr. Karen George is a clinical associate professor of obstetrics and gynecology at George Washington University School of Medicine and Health Sciences in Washington, D.C. Prior to that, Dr. George was the residency program director at Dartmouth-Hitchcock Medical Center for 15 years and now serves as the chair of the Council on Residency Education at the American College of Obstetricians and Gynecologists. Dr. Monica Mclemore. Dr. Mclemore is a tenured associate professor in the Family Health Care Nursing Department at the University of California, San Francisco, as you can tell from her background. Dr. Mclemore is an affiliated scientist with Advancing New Standards in Reproductive Health and a member of the Bixby Center for Global Reproductive Health. She retired from clinical practice as a public health and staff nurse after a 23-year clinical nursing career. Dr. Mclemore's program of research is focused on understanding reproductive health and justice. She is a recipient of numerous awards and currently serves as chair-elect for Sexual and Reproductive Health section of the American Public Health Association. Dr. Mclemore was inducted as a Fellow of the American Academy of Nursing in 2019. And Mr. Michael Sandwith. Mr. Sandwith is Vice President of Payment Reform and Transformation at United Healthcare Community Plan of Tennessee. United Healthcare is a division of United Health Group, which is a diversified health and well-being company with a mission to help people live healthier lives and help make the system work better for everyone. In this role, Mr. Sandwith has been responsible for the last 5 years of developing, implementing, and managing TennCare, which is Medicaid in Tennessee, their value-based programs around episodes of care, PCMH, and health homes, leading the work that United Healthcare is doing within those programs. So welcome to you all. So first, let's open up the discussion. Let's first start with the foundation of this conversation, which is really around the value of the midwifery model. You all represent different key perspectives: birth equity for individuals, healthcare provider perspectives, and health plan perspectives. For midwifery models to succeed, first and foremost, the key players need to see and buy into the value of the model. Those values will not necessarily be the same, but areas of alignment and shared values can really help set the stage for action, overcoming barriers and success. So I'd like to hear from all of you first, your perspectives about the value of the midwifery-led model of care from your unique perch, including how issues around disparities and equity connect to that value. Also appreciate any quick reflections you might have on where misalignment across stakeholders has presented obstacles that perhaps folks in our audience should anticipate. So Dr. Mclemore, would you kick us off?
Absolutely. First of all, I use doctor and she and her pronouns, and folks have my consent to be able to post on social media and to be able to use my words. First, I'm deeply honored to be participating in this important webinar series in this particularly important conversation, and I want to thank the organizers for inviting me. So let's jump into it. 3 important points. I had to write these down because you know I will go on a rant about this. First, pregnancy is not a disease state to be managed. It's a normal physiological condition that needs to be attended to and witnessed. Birthing is a reverent event that deserves respect and humility. Shepherding new humans to this plane is a process that for centuries has ensured the propagation of our species. This is a really radically different way of understanding birth than the risk categorization that dominates obstetrics. So when I talk about and when I think about birthing people, this distinction needs to be made. Next, regardless of age, income, education, insurance, and/or marital status, Black women carry the greatest burden for poor reproductive outcomes across the spectrum. Pregnancy is the condition, and there are many outcomes of pregnancy: abortion, birth, miscarriage, surrogacy, stillbirth. So we need to use a life course perspective to understand that continuity is required in the care provision for those who carry the greatest burden. And finally, humans have been birthing since the dawn of time. The midwifery model of care is shown to have superior outcomes across the globe and is the primary model of care in many places. Yet here in the United States, our uptake and scale of the model is hampered by a lack of courage, a lack of political will, a lack of available workforce, and rampant disrespect for birthing people and the constellation of individuals who surround them. So until we can change that narrative, I don't necessarily know that we're actually going to be able to achieve our goals.
Thank you so much, Dr. Mclemore. Dr. George?
Hi, thanks for the introduction, and it's great to be here as well. And I guess I'll start by saying that my views are my own. They don't represent any of the 3 organizations that I work with. I guess as an obstetrician, I acknowledge very much what you've just said, Dr. Mclemore. I feel that my specialty has been remiss over the years, and that we need to right a lot of wrong. And I think that we are acknowledging that and moving forward. From my perspective as an obstetrician who has worked with midwives throughout her career, I would say that there really are differences in our perspectives and in our training. Midwives, as you said, really see birth as a normal physiologic process. And physicians are really trained to see it as an endless list of possible ways that it can go wrong, and unfortunately. And labor and delivery units, especially those who serve birthing people insured with Medicaid, are often very busy, and they're basically set up as intensive care units. There's pressure for efficient throughput, and patients unfortunately get put on a time clock to make room for the incoming. Often decisions are made because of unit and even hospital volume and acuity. And really, in contrast, in my work with midwives over the years, have found them to really embrace a different viewpoint. They often have fewer patients than the physicians. They're able to spend more time, more uninterrupted time with their patients. And with their focus on normal birth, healthy women are really much more likely to engage with the process, and they practice watchful waiting, and often this relates and results into a normal vaginal birth. From the health policy perspective, midwives really have tremendous value, and I think that this was already alluded to by both of you, and also last month at the meeting when Dr. Moore went over the robust evidence to support better outcomes. So we know very much that midwifery care results in lower cesarean delivery rates, higher VBAC rates, overall lower utilization of interventions, including epidurals in low-risk patients who are attended by midwives. Hospitals who employ midwives have lower cesarean delivery rates, and patients are much more satisfied with their outcomes. As we know from the Strong Start study, this carries over into better outcomes for those who are insured with midwives. We're learning more and more how concordant care with a provider who shares a lived experience really improves that engagement and outcomes outcome. And finally, from my perspective as an educator for many years, I have to say I was trained to be a better doctor through my interactions with midwives. And of the 1,700 graduating OBGYNs last year, half of them were trained with midwives. And I think that really makes a big difference. And many of them are specifically seeking to continue a collaborative practice and to have midwifery colleagues. So that's all I'll say for now. Thanks.
Thanks so much, Dr. George, for teeing that up. And Mr. Sandwith, from the health plan perspective, your thoughts on the value that this model brings from the work that you do.
Well, thank you so much for the introduction. I kind of feel like a thorn between many roses as I get started with this. For me, I've been in healthcare for about 35 years, developed the first perinatal bundles in 1985, did the first mobile maternity engagement app in the state of Wyoming Medicaid population, and now in Tennessee, developed perinatal episodes of care in which we have almost 8,000 births within United. How I got into the birthing center aspect was I was approached by TennCare that they had met with a company called Baby and Company who was building birthing centers within the state of Tennessee. And they wanted us to meet with them. And immediately when I met with them, I immediately saw the value that they could provide and also provide another side of care for women within the Medicaid program. And so I immediately built a relationship with them, understood what they were trying to do, and to position them within the episode of care program in which they could be participating just as well as any other OBGYN in the program. It was relatively unheard of because TennCare asked all the MCOs to do that. And as a result, we were able to be the first MCO to provide that benefit to any Medicaid woman within the state of Tennessee. Unfortunately, Baby and Company was only located in the greater Nashville area, so it kind of limited that. But that aspect of providing another side of care for somebody and provide them another opportunity to engage with the system allowed us to help with their cost and to develop their quality measures. So I immediately saw its value, and we implemented it, gosh, almost 2 years ago.
That's great. So let's dig in now a little bit more into the how of all of this and some of the different approaches. Given these perspectives, I'd like to hear from all of you, about the types of initiatives that you have launched in your work in this space. How's your work? How's it promoting network access to midwifery care models? Issues of benefit coverage and payment of services, and how you have been able to explicitly incorporate equity into each of your approaches. So, Mr. Sandwith, let's pick up where you just left off. Tell us a little bit about how United has approached supporting this model, given all of your work to date.
Well, I'm kind of an out-of-box sort of person in regards to that. So basically, I've been very focused in Tennessee on how we can promote that. The barriers that you're going to find, and I'm going to talk about that, is there's a lot of barriers within a health plan, just about to get anything done if you're going to contract with them, if you're a little bit outside the box. I do find it very beneficial that in the state of Tennessee with TennCare, they went down a value-based methodology, which allowed us very easily for me to bring the birthing center and midwifery within the solution. So I had a value-based model, which was episodes. So to be able to bring that in, but even as a champion of that and being within the health plan, there were numerous barriers, starting from contracting. What paper do I put it on? Meaning contract paper. Is it a provider? Is it a facility? All of that to go through. What's going to be their episode of care costs? What are all the components that go into that? So I know exactly the model of care because we sat down in education all the way to delivery about that. That was key, but you have to have a champion. If you don't have someone in the champion within the health plan, it's going to help you through those barriers. As most cases, it's going to fall by the wayside. So I took it upon to be the champion, drive it through with the chief medical officer, with the CFO, with contracting, to move that along to where then they became a participating provider within the network. So yes, there are a lot of barriers. I will talk later about the recommendations of that, but I do think you need to first understand if you're looking at another state, research that health plan, determine if that state is a managed Medicaid state, what health plans participate there, are there any value-based programs, what are they doing in perinatal? Because Ohio has the same episode of care program as Tennessee, as does Arkansas. It was the same consultant. So you can replicate that and understand, try to figure out where can you position your solution within that entity.
That's great. Thanks, Mr. Sandwith. Dr. George, building on that approach, I'm curious from the work that you've done in your practices. Would really like to hear the provider's perspective of initiatives that you have launched that bring midwives into your obstetric practice. How have you done that? What works well in doing that, and what are some barriers that folks might anticipate in thinking about how to weave in the midwifery model into the practice?
Thanks. So yes, I've worked with midwives since the late 80s. They were part of my training as a resident in New Mexico, and then in New Hampshire, where I was for 15 years, 20 years almost, we had a very busy midwifery practice. And now here in DC, I work with a big midwifery group as well. So I guess I've seen a lot of different slightly different types of collaborative care along the way. But I think that the group that I'm with right now has been working with George Washington for over 15 years. And since that time, we have really institutionally seen our cesarean delivery rate decline significantly. In fact, we're the lowest in the city, and our midwifery group has won many awards for the care that they provide. We're a teaching hospital, so at any given time, we have students, both midwifery students and medical students, sometimes nursing students. We always have on call 2 faculty physicians, a faculty midwife, and then some combination of resident students and a midwifery fellow. And we work really collaboratively with our midwifery colleagues, and we function very much as a team. So they have guidelines for when to consult with us, and we're available to them at a moment's notice if they have something that they encounter as a complication. Likewise, they are often available to take over for us if we're stuck in surgery or unavailable, or honestly, if we have a patient that we feel who would really benefit from some extra TLC, to be honest. So in the last 5 years, I've been here only 3.5, but in the last 5 years, we've made a very conscious effort to recruit minority midwives into our practice. We have a very interesting midwifery fellowship at GW. And in the last 5 years, we have really made it our priority to recruit midwifery fellows of color who felt like they needed some additional training or wanted to give them sort of a softer entry into practice. So it's more of a supportive environment for those folks coming in right out of school to gain a little bit of experience with some extra people around to help make that transition. So sometimes these fellows sub in for our residents and they get significant experience dealing with higher risk situations. But honestly, as a faculty member, when I work with one of them, I always learn some better way to do counseling or a better way to approach somebody who's super anxious or a new position to coach a baby out. So it's a learning collaborative. And I know you talked about the quadruple aim at the very beginning, Tricia. I think it really adds a lot of satisfaction to the work I do to have midwifery colleagues. Most of the graduates of our midwifery fellowship choose to work in underserved areas, and they leave with a lot more confidence and skills to take care of them, to take care of their patients in the future. So as we look at opportunities for continued collaboration, we work really closely together in terms of quality assurance. We have really taken on several QI projects, including creating better shared medical appointments or group appointments for patients. We're both working, both groups are working together on an AIMS safety bundle to lower disparities in our office and our practice. So those are a few things, but many more besides that. But really the value added from just that satisfaction is tremendous.
To Mclemore, especially, and some nice connections to the work, Dr. Mclemore, that you've done on workforce and some of your really extensive research in that, because that really is such a critical component to the model. It's not just a midwifery workforce, but a workforce that is really responsive to the community. And so I would love to hear a little bit about what you've learned on that front through your research, and what do you think is important for health plans and state Medicaid agencies and even providers? Like what role do they have to play in helping to stand up a workforce that really reflects the community that we're trying to serve?
Well, I appreciate the comments, the other panelists. And, if the last 10 months have taught us nothing, it is that we have the opportunity to be as bold as we want to in our thinking. So I'm gonna try and make 5 points in under 5 minutes because I could talk about this all day, particularly in the context of the fact that California has finally decided to remove physician supervision from both midwives and nurse practitioners. I have been thinking about this and studying this for a very long time. So number one, to be provocative, we need midwifery agnosticism. And I say this as a tenured professor who's currently on a sabbatical who sits with the midwifery faculty in a nurse midwifery program. But quite frankly, I spend a lot of time with licensed midwives and professional midwives and lay midwives. And so at some point we need to have a discussion about the fact that regardless of whatever their educational preparation is, that if they are safe and knowledgeable providers, that they should be able to work wherever we need them. So I said it, I'm gonna say it. Number two, there are demonstration projects that doulas and midwives and pelvic floor folks and nurses and physicians have attempted to put forward, which I like to think about as wraparound services or the essential services that we need in order for midwives to be successful. One such project is the Aspiring Black Midwives that Asmara Gebre, who leads at Zuckerberg San Francisco General. She coaches them, she mentors them, she reads through statements to get into school. You know, she allows them to bond as a cohort to really be successful. And I think we need more programs like that. I think we need to talk about racial concordance and really teaching the history of this country and why racial concordance is so important. And as somebody whose PCORI grant just got rejected for wanting to actually head-to-head study racial concordance and prenatal care, you know, provision, both in group and as individuals, I think we need to have a really frank and honest conversation about what we mean when we talk about racial and social and cultural concordance. Because people seem to get this around language, but they don't seem to get it around race and class and social status. So at some point, we need a discussion around that. We also need to have a discussion about our current workforce and our future workforce. One of the first studies I did when I completed my dissertation was I worked with formerly incarcerated individuals to figure out if they could be successfully trained as birth doulas, right? Would bringing them back into institutions create harm? Were they able to actually support birthing people, right? And one of the things we found is not only can they be successfully trained to be birth doulas, but two of them moved forward to advance their education. These were all, you know, women of color. These were all low-income folks. These were people who were moms during their carceral experiences. We have to invest in not just the current workforce, but we have to build paths to the future workforce, right? And one thing we could easily do is for folks, those of us who serve birthing people, we need to view the people that we serve as our future workforce, right? At some point, if we actually thought or had a goal that 20 to 25% of the people we serve will ultimately make up our staff. We've done this at Homeless Prenatal Program here in San Francisco. I know the Preterm Birth Initiative has done this. You make different decisions when you're hiring folks. You make different decisions when you're thinking about staffing. You make different decisions when you think that the people that you serve are penultimately going to be your workforce. I also think team-based care and team-based models are the way to go. I'm really glad to hear Dr. George talk about the co-education with midwifery. We need to bring the nursing students in and the psych folks and the pelvic floor folks, right? We need to all be together, the pharmacy folks. We need to be together in a classroom before we all together in a healthcare situation where we all have to somehow work together, knowing we have different roles, we have common goals for serving people. And the last thing I'll say is we need to build paths to the workforce, right? The biggest intervention that we could do as a nation, if we really wanted to unleash the birthing workforce and to have it be racially and culturally concordant, is we could cancel student debt, and we could cancel student loans, or we could create programs like I went through when I was a baccalaureate nurse in 1988. I agreed to work at the hospital that I was born at in Trenton, New Jersey, and they paid my fees at the university where I got my BSN. And if I worked for them for 2 years, then I didn't have any debt when I came out, right? We need to start thinking about programs like that again if we really, really want to optimize workforce towards midwifery.
That's great. Thanks for those 5 points. A lot to think about, and I appreciated the roles that different organizations can play in doing all 5 of those things you called out, Dr. Mclemore. And Mr. Sandwith, I want to turn to you and hear about, first, if you have any reflections on what Dr. Mclemore and Dr. George have put out in terms of, what they're seeing on the ground and how that relates to what you're trying to do at your health plan, but also, really give you an opportunity to share how your efforts as a health plan are playing out in terms of promoting access to the model and use of the model. You noted earlier when you first started working on this issue, there's only one birth center in Nashville, and obviously the access and interest in utilization of services is it really is an area where the health plan can play a huge role. So I'm curious to hear more about your experiences with your work in this area.
Well, really, there's a number of things that position it correctly in the marketplace, and I think what the care model, or however it's been developed, needs to be team oriented. There needs to be cross training and so forth. But to me, I learned that by just the engagement with that birthing center and those that were working there. But really, what I tried to coach them on is that you're going to have to accumulate some data. I kind of put that out there in the PowerPoint that I presented, but how many patients are you seeing? What's sort of non-medical transfers? What are medical transfers? How many births? And what I really found very interesting, and I met with a number of them within Tennessee, was that one of the key components was they didn't have a marketing plan. As to how were you going, if I was going to include this as a benefit, how are we going to make those TennCare members aware of this option, which most people forget about? It doesn't come by divine intervention. You really have to develop a plan. So I had 2 interns who were very interested in the birthing center, midwifery, and so one of their projects, this was 2 years ago, their summer, was to develop a marketing plan, an awareness plan, to learn everything about the birthing center, their capabilities, and develop a strategy of how we're going to make people aware, members aware of this capability. And I'll be glad to share that, send it to you all. There's nothing in there but it does give you a platform of saying, okay, we all believe in it, we want to do it, so how are we going to move the needle to make people aware that this is an option? So we looked at goals and expectations. Also in our data, we started to track how many Medicaid women were now coming in there. There was a big push with the birthing center that you had a lot of private pays. They really didn't have any contracts with health plans. So really, majority of those people found that the cost for having that child were far less at the birthing center because they were a cash pay. So I really think you have to spend some time on what your marketing plan is. You don't have to have unbelievable data, but you have to have certain components of your data that creates accountability and not so much accountability, but credibility of what you're doing. And I've included some of those, of which I was able to get. Then, since it's going to be in a value-based program, you've got to start looking at what kind of metrics do you want to track. Statistically, for the perinatal episode in Tennessee, we're below 30%. We're actually 29.8. And we've done that through the episode of care by educating OBGYNs that here's other options other than to do a C-section. And so we've worked really hard on that, and the birthing center gave another option. And then I sat down with the birthing center and said, okay, what are the metrics that we want to track? And how can the health plan track that and provide it so that we can move forward to either publish those or to expand that? And then for me, my mind always thinks more bundles and episodes of care because it's more value-based. You get into fee-for-service, sometimes it gets a little wacky with how they're going to contract with that. But if you've got a value-based episode or bundle, you pretty much can put it in what's unique for the birthing center. Where are the savings going to be? We're not going hospital. You know, what are the professional fees? All of those cost categories I break down and sat with them and said, okay, what is it going to take in an episode of care for you all to be whole, as well as get some sort of profitability by doing this episode of care? That took me about two months with them. And then I took that to contracting and said, okay, here's what the episode of care is going to be with the birthing center. And it was one fee with these metrics tied to it. And the contract took maybe 4 days to get completed and signed because it laid everything out according to the way the health plan was thinking. That's the way I kind of approach it. And I'll talk very quickly about when you're presenting to a health plan, do your research on the front end. Try to make sure you've got a champion. And when you're doing your presentation, you know, talk about your analytics, talk about your program, how you'd like to do pricing and performance. And it's really key. And I think if you, at the end of that, you tie that to a marketing plan, then it's going to take the workload off of that health plan. And the health plan has a lot of ways of reaching out to people. They don't advertise it. A way to send newsletters out to members. They have different seminars and that sort of thing. So for me, it was a very exciting process. I got it. I'm a little bit more, I'm left and right brain, so I understand the solution, and I went and implemented it for them. And I got a lot of compliments from TennCare about developing that for their membership.
Great. Thank you so much, Mr. Sandwith. I have another list of questions, but I am also seeing that the chat box is lighting up. So I want to make sure that our folks in the audience have a chance to pose questions to our excellent panelists. So at this point, I am going to hand it off to Preeti Kanal, who's going to share questions with the panelists and get the audience Q&A going. So Preeti?
Yes, thanks so much, Tricia. So the first question, it sounds like a lot of people are asking about what Dr. George was talking about earlier about what works in incorporating midwifery care in hospitals, but they're more curious about some of the barriers. And one person mentioned one huge barrier to the growth of midwifery is the lack of clinical education opportunities. This is often due to perceived competition for residents, unfounded fear of increased liability, and lack of funds. What do you think of implementation of broad national programs that encourage or obligate institutions that train OB residents and receive GME funding to simultaneously train midwives?
It's a fabulous idea. You know, I think that is completely the case, that there is not funding for midwives to receive the care. I mean, receive the training that they need in order to do it. And I think Dr. Mclemore can probably speak to this better than I with her expertise in workforce, and in nursing as well. But I think that we need at least twice as many midwives as we have per doctor. It should be at least a 2-to-1.
And to piggyback on that comment, because I agree, at the same time, we have a strategy problem. So, you know, if there are 39 currently accredited programs in midwifery in the United States, you know, that's not going to get us to the workforce that we need. When you layer on top of that, that there are 108 accredited historically Black colleges and universities, 39 of which have schools of public health, medicine, and or nursing, and 0 of them have programs in midwifery, Houston, we have a problem. So at some point, we will need to have an infusion of funds that will allow for, and I have a ton of ways to think about this, but that will allow for, those educational programs to be able to have capacity. But this is why birthing people, this is why doulas, this is why our existing workforce needs to see midwifery as a potential path to being able to work. And we have to build those paths. We can't just wait for the academic institutions to catch up. And so part of it, doula work in and of itself is amazing and it's incredible. And I know that for some people, doula work has been an on-ramp to midwifery. And that's one of the reasons why I think we need to build that path. It's another reason why I'm agnostic in terms of education. I know that there are structural barriers and a supremacy of nurse midwifery, but there are other midwives that do really, really great work. And so I think we need to have an honest conversation if we really want to have a workforce discussion about where are we going to financially incentivize opportunities for people to become midwives.
Point.
There was a question in the chat that I personally wanted to answer. And because I asked this question myself and it's very, very close to home. There's been an observation that there's not been any midwives on the 2 panels. And I brought that to Dr. Moore and she's aware of that and has definitely teed up midwives to participate in this webinar. It felt that it was very, very important that experts who really could to set the stage to be able to do that. But I appreciate that point. And yeah, I brought that up too.
Great, thank you so much for that, both Dr. George and Dr. Mclemore. Mr. Sandwith, a few folks are asking questions about your recommendation to find the champion. What roles are best positioned to act as champions? And how about folks who don't have C-suite leaders as co-champions? How do you create momentum to shift models of care?
Well, I think in every health plan, you want to start with the business development person or business innovation. I know with United, every health plan has a business development person, and that's where you want to enter and set up that first meeting. The first meeting should involve the CMO, the clinical team at that health plan, and if possible, any of the contracting people. And from that meeting, you're going to figure out pretty quickly who's really engaged and who's going to be your champion. So from that, then it becomes an aspect of how do you position that within what offerings that health plan has in terms of value-based programs. Are they doing anything unique in the perinatal side of the business and so forth? But I can, if anybody wants more detailed, I can kind of lay that out in a lot of detail of how to position it, because it's very easy to set a meeting. And the other last thing I say, if you have one meeting, don't forget to set up the next meeting, because if you do, you're out of the loop. Because so all of a sudden those people no longer can answer emails for another meeting. So when you're in there, you push it, make sure you have a next meeting, because the next meeting might be 5 different people walking you through the process of getting your solution implemented. That answer.
Can I build on that question though? Is there a role for philanthropy? Is there a way to collectivize this so it's not every midwifery group trying to go to a health plan to, like, isn't there a collective way we could be thinking about this? Or is there a consortia that can make that happen?
Yeah, what you have to understand is a lot of health plans are matrix organizations. Matrix meaning that they have different entities and they kind of operate as different companies. What I try to do is do a pilot study. Once it's successful, then I push it up to the national contracting people. So then I can get approval to implement in a broader region. That's kind of been my background. So I recommend what happens a lot of times is if you go to the national level, most of those people don't even understand what you're talking about. I mean, in a good way. They're looking at all different solutions. But if you start at an individual health plan area, then you've got people that are involved with it more, and they're going to be your champions if you want to move it up the chain to national contracting. And in most cases that I've done pilot studies, not every one of them, but the majority of them have gotten a national contract. Just because we proved it by a pilot study, the value, and had the support from the health plan to move it up the chain. I hope that answers your question.
Yeah, it was very helpful. Thank you.
Thank you. And then, Mr. Sandwith, access to clinical data, measure development, and reporting are frequently seen as barriers to success for bundle payment concepts. How is UHC addressing access to clinical data and measurement development for maternal bundles of care?
Well, in Tennessee, every provider is mandated to participate in Medicaid. So every OBGYN who's in the Medicaid program has to adhere to the episode of care program. And that includes, they operate within two thresholds, being commendable and acceptable. If you're below the commendable, you're eligible for outcome payments. If you're above the acceptable, you're paying the health plan back for poor performance. But then it's all tied to quality measures. So how it all started is a technical advisory group set up the metrics, and it was mandated that those would be the metrics, which we're now looking at again to see if we want to add any other metrics. But yeah, I have all the data for 5 years on every OBGYN in the state of Tennessee, on every procedure that they've done for a Medicaid recipient. And so our perinatal program, over the last 5 years, we've generated $8.6 million in savings, and we've reduced our C-section rate from high 40s down to below 30. So we've done a lot, and you don't need to boil the ocean with your quality metrics or the data that you're collecting. Is keep it simple and what's going to provide value in implementing your solution.
Great. I'm going to switch gears slightly. I want to ask Dr. Mclemore a question about your expertise as a researcher in meaningfully bringing community voices into research. And so based on experiences, we'd love to hear your advice on how state agencies and health plans can intentionally bring communities of color to the table as full partners in their endeavors to co-develop initiatives and approaches that meet community needs and expectations. What are some of the best practices?
Well, as somebody who had to retrofit community engagement onto one of the 3 pregnancy COVID-19 registries, one of the first things I will say is community engagement needs to become the standard from the beginning, because the retrofit is very, very difficult, right? To try and pull together a community advisory board, to try and pull together a national community advisory council, when a study has already started or when a project has already begun, when decisions have already been made, when budget documents, which are moral ones, have already been determined, it is very difficult to retrofit community engagement. So in my opinion, one of the things that me and my team are trying to do is to establish the model of how you pull together a national community advisory council such that can be leveraged across different institutions. And we're trying to do that through the Clinical Translation Science Institute or the CTSI's academic institutions, so that there are standing individuals who are ready to be able to be trained, paid a living wage, and able to, really represent community voice on projects. That's number one. Number two, I think we need to directly fund community doulas, community birth workers, right? I know that makes people uncomfortable, but the truth of the matter is everyone talks about the mechanism to getting there, but by further institutionalizing them, they lose their secret sauce, right? There's something that those individuals are doing, and we need to pay that and pay for that. I also think organizations and institutions need to show up, right? People talk about building tables and inviting people to the table. Sometimes you have to go to the community baby shower. Sometimes you have to show up at the community meetings, right? It's not just them coming to us. We have to prove ourselves trustworthy. So we actually have to go to where they are meeting. So for me, and this whole idea that people serve communities that they don't live, work, pray, play, and thrive in, I think we need to have an honest conversation about that at some point, because I think it's completely problematic to not be deeply embedded in the communities in which we serve. And that causes, some barriers and roadblocks from the beginning. So pay people a living wage from the beginning to opine about how these projects and these implementations start. We need to directly fund community-based birth workers, because I think that that's important. And we have to show up, right? Like, we actually have to be participating in community events. We have to be, showing our interest in their health and well-being, not just at labor and birth, but in the life course.
That's great. Thank you so much. There are so many great questions that the audience submitted, and unfortunately we can't get to all of them, but we will follow up with a document answering the rest of the questions for you all. So please look out for that. And I'm going to hand it over to Tricia.
Yeah, so that hour flew. I want to give a very sincere thank you to our panelists. I think clearly we can continue this conversation for the rest of the afternoon, but unfortunately we can't. But I'm going to hand off to Chloe, who's going to talk a little bit about some follow-up items that we're going to have that will help connect the Q&A with our terrific panelists. But thank you all. I feel like I've learned a tremendous amount and really appreciate your time and expertise.
Thank you.
Hi, everyone. At this time, everyone should have received an email with the link to complete today's brief 5-minute session evaluation. I've also just put the link in the chat box for you. We want to thank everyone who alerted us to the minor issues with our previous evaluation form. Those have been resolved, so we don't anticipate those happening again. As I mentioned, our response rate for last session was around 40%. That isn't bad considering that we had those issues with the form, but as I mentioned, our goal today is to double that with our 80% response rate. Your feedback is extremely important as it helps us make adjustments to meet your learning needs as we go through the learning series. If you did not receive the email with the session evaluation, please contact me. My email is on the slide. As with session 1, we'll be sending the presentation slides, a Q&A document, and the archived recording of today's sessions by email to you within the next 2 weeks, and these will also be posted on the IMI and CHCS websites. Finally, our next session is scheduled for Friday, December 11th, and will be focused on licensing, credentialing, and contracting in Medicaid. Keep an eye out for the pre-session email with the agenda and required pre-session activities. If you haven't already, please remember to add Jennifer Moore to your email contact list to ensure that the series emails are not sent to your spam or junk boxes. Her email is also posted on the slide. Thank you for your participation in today's session, and we look forward to seeing you all again in December.